As an ACP crew, this is how we would manage a patient who is unconscious with no pulse. Once you've established that they have no pulse, quickly start CPR. Get the pads on and determine if it's a shockable rhythm or not. Shockable rhythms are VFib and pulseless VTAC. Non-shockable are asystole and PEA. If it is a shockable rhythm, deliver the shock and immediately resume CPR for 2-minute interval. At this point, you want to establish IV access, and once the 2 minutes are up, you want to do your next second rhythm analysis. If it is a shockable rhythm, deliver the shock immediately. If it is a non-shockable rhythm, determine whether it's a ROSC or a PEA. If it is a ROSC, initiate post-arrest care. If it is a PEA, continue CPR for the next 2 minutes. After delivering the shock, immediately resume CPR for a 2-minute interval. Within this period, administer epinephrine, 1 milligram. At the end of 2 minutes, do your third analyze. If it is a shockable rhythm, deliver the shock immediately. If it is a non-shockable rhythm, determine whether it's a ROSC or a PEA. After delivering the shock, immediately resume CPR for another 2-minute interval. Within this interval, administer 300 milligrams of amiodarone. At the end of the interval, do your fourth rhythm check. Unlike a PCP medical cardiac arrest, ACPs are allowed to do an unlimited number of analyses on scene. Every 4 minutes, 1 milligram of epinephrine is administered. Amiodarone, on the other hand, is administered twice, 4 minutes apart. The first dose is 300 milligram, second dose is 150 milligram. Following a rhythm check, if the patient is in an asystolic or PEA rhythm, immediately resume CPR. At appropriately timed intervals, you will administer epinephrine every 4 minutes. At which point, at the end of the 2-minute interval, you are going to do your next rhythm interpretation.
Here is the overview of the whole algorithm. Epinephrine is classified as a sympathomimetic. It is both an alpha and beta adrenergic agonist. It produces some beneficial effects in patients during a cardiac arrest. These alpha adrenergic effects of epinephrine can increase coronary and cerebral perfusion pressure during CPR. A 2015 trial assessed short-term and long-term outcomes of epinephrine. They compared administration of standard dose epinephrine during cardiac arrest versus no administration at all. Right now, the guidelines state administer 1 milligram dose of epinephrine IV or IO every 3 to 5 minutes during a cardiac arrest. For both survival to discharge and survival to discharge with good neurological outcome, there were no real benefits with standard dose epinephrine administration. There was, however, improved survival to hospital admission and improved ROSC with the use of standard dose epi. Epinephrine increased survival to discharge by only about 1%. Clinical data confirms that epinephrine administration during CPR can increase short-term survival, but may point towards no real benefit or even harm. Studies have shown that the first round of epi causes a huge spike in BP. But with subsequent doses, the increase in BP drops drastically and almost is negligible by the third dose. Another study states that epinephrine impairs myocardial function despite increasing its coronary perfusion pressures. After 10 minutes of CPR in dogs, myocardial ATP depletion and lactate accumulation increased after the administration of epinephrine. The effect was attributed to beta-adrenergic inotropic and chronotropic increases in myocardial oxygen demand. Let's review. Epinephrine in cardiac arrest. Increase myocardial oxygen demand. Increased risk of post-arrest arrhythmias. Higher doses have not been shown to improve patient outcome. And lastly, vasoconstriction effects diminish over time. So why is epinephrine still used in medical cardiac arrest? Well, research states that epinephrine helps increase the chances of a ROSC. Current research proposed that there is an urgent need to reassess how and to whom we administer epinephrine to. What we suggest, instead of administering 1 milligram of epinephrine every 4 minutes with no max number of doses, maybe we should set a max number of dose to about 1 or 2.
With regards to the use of amiodarone in cardiac arrest, it is the antiarrhythmic drug of choice when it comes to refractory VFib or pulseless VTAC. Support for its use is primarily based on 2 randomized controlled trials conducted in 1999 and 2002. These studies demonstrated that amiodarone was effective at increasing the survival of cardiac arrest patients in shock-resistant rhythms to hospital admission, and therefore helping improve ROSC rates. As such, evidence for the use of amiodarone in cardiac arrest is considered level A evidence, the highest quality of evidence as per the American Heart Association's 2015 guidelines. Kendenchuk and colleagues conducted a randomized, double-blind, placebo-controlled trial in Washington state which included approximately 500 subjects. Subjects were included in the study if they were in cardiac arrest due to non-traumatic causes, in VFib or pulseless VTAC, had IV access established, and had not been yet resuscitated after 3 or more shocks. Upon meeting eligibility criteria, subjects were either given 300 milligrams of amiodarone, or the placebo, polysorbate 80, via IV, and then rapidly infused with 5% dextrose. Both the active drug and amiodarone were packaged and administered identically. Kendenchuk and colleagues found that 44% of subjects given amiodarone survived to hospital admission, whereas only 34% of those given placebo survived. In 2016, Lena and colleagues conducted a systematic review and meta-analysis of the literature on the use of amiodarone in cardiac arrest in out-of-hospital settings. 4 randomized controlled trials and 6 observational studies were eligible according to their research criteria. Lena and colleagues concluded that amiodarone increases survival to hospital, but has not yet been demonstrated to improve survival to hospital discharge with good neurological outcomes. Usman Ali and colleagues in 2018 came to similar conclusions in their systematic review after analyzing 14 randomized controlled trials and 17 observational studies. The risk of compromising CPR quality is a legitimate concern, but the data show that patients benefit from amiodarone by having improved survival to hospital, and therefore an increased possibility of meaningful hospital discharge. We recommend that amiodarone continue being used to treat refractory VFib or pulseless VTAC in pre-hospital settings. However, further research should investigate whether amiodarone improves patient survival to hospital discharge with meaningful neurological intactness. As well, the current evidence on amiodarone should not preclude research into other treatment options with the potential for improving survival to hospital discharge.
Based on the research presented, one might doubt the clinical significance of drug administration during a medical cardiac arrest. In fact, high-quality CPR and early defibrillation are the only 2 interventions validated by evidence-based research. Thus, as a group, we think it's important to bring it back down to the basics, to focus on these interventions to improve the clinical outcomes of a medical cardiac arrest.